So welcome everybody to Maternal and Infant Health Canada's educational webinar series. Today is, the topic is hypertensive disorders of pregnancy among women in Southwestern Uganda, and it's going to be by Dr. Henry Lugobe. As Dr. Lugobe mentioned, I always start these webinars describing a little bit about Maternal and Infant Health Canada. So we are a global public health collaborative working to improve the health of women and children around the world while seeking equity-driven solutions to a more sustainable world. Our pillars include education, research, and innovation. We're made up of doctors, researchers, public health professionals, and traditional medicine practitioners from around the world. Today's webinar is co-sponsored by the Global Women's Health Network, alumni of the Harvard Takemi Program in International Health. If you'd like to keep up with all that's happening with us, you can, and you have a lot of different ways. You can, for those who really like WhatsApp, I will put our email and you can put in the chat group right now that you'd like to be part of our WhatsApp and give us your number. If not, you can go to our website and see all of our previous webinars. We do them every 2 months and we record almost every single one of them. So you are welcome to look at those at your own leisure. We also have a Facebook page and a LinkedIn page. And so what I'm going to do is put those right now, in our chat. So for those of you who want them, there they are. All right. So as I mentioned, we host 6 webinars a year. If you have any ideas for webinars, you would like to speak on a webinar, or if you simply just want to come watch some more, feel free to reach out to us, mycancares@gmail.com. We do appreciate your feedback, and at the end of the webinar, you will see a prompt to fill out a survey. I promise it's a very, very short survey, but we just really like to get feedback to make sure that everybody's really enjoying the webinars and see what you like, what you'd like more of, all of that. As with all of our public webinars, I have to say the following disclaimer. This course and handouts may be contain general information about medical conditions and treatments. The information is not advice and should not be treated as such. Throughout the webinar, if you have questions or comments, you're welcome to put them into our chat. I will gather all of them at the very end. We'll have a lively comment, question, discussion. So please stick around for that. As usual, I am your moderator, Dr. Emily Solomons. I'm a doctor of traditional Chinese medicine and the co-president of the Obstetrical Acupuncture Association, as well as a MIHCAN board member. I am zooming in from the ancestral and unceded lands of the Coast Salish people. We also have Dr. Farah Shroff here, our wonderful, incredible, tireless, fearless founder and lead of Maternal and Infant Health Canada, who is also a former Takemi Fellow at Harvard University, and she has joined us. So hello, Farah. Not sure if there's anything you want to say before I introduce Dr. Lugobe?
Hey, I'm so excited to hear this webinar. Yes, it's really, really, really wonderful way to start a Monday.
Perfect. So we have Dr. Henry Lugobe here today, and he is a junior faculty member in the Department of Obstetrics and Gynecology at Mbara University Science and Technology, the leading academic research institute in Western Uganda. He completed his residency training in OBGYN at the Mbarara, I should know this, I've been there, University of Science and Technology. As a practicing physician at the regional hospital, Dr. Lugobe's central focus is to improve the care of patients, particularly maternal and newborn outcomes in this resource-limited setting. His research interest is in high-risk obstetrics, including hypertensive disorders in pregnancy, as well as maternal and perinatal mortality audits to improve obstetric outcomes. Dr. Lugobe's long-term career goal is to become an independent academic clinician with expertise in developing, testing, and implementing innovative strategies to improve maternal and newborn outcomes. This will enable him to establish his position as a leader in women's cardiovascular health. And we are so incredibly fortunate to have him here today to speak to us. So I'm not going to bore you anymore. I'm going to pass you right along to Dr. Lugobe. Thank you so much for joining us.
Thank you, Emily, for your kind introduction. Thank you, Farah, for the invite. Let me try to share my screen. Good morning, good afternoon, and good evening from everywhere you are. You're welcome to this webinar, which is really sharing my experience on hypertensive disorders of pregnancy. I have no disclosures, and what I'm sharing in part is research work. The next part is really my opinion, and it's really open to discussion. And I hope we enjoy the next couple of minutes through this, and I will allow some time for a Q&A. And if it's a lot of time with a few questions, then I'll talk more. So no worries. Yeah. Okay. So I would safely assume that we know what hypertension is. So if this hypertension occurs in pregnancy, for now we shall call it hypertensive disorders of pregnancy. There are groups of hypertensive disorders of pregnancy, but let's take it that this is hypertension in pregnancy or pregnancy hypertension. It's common, complicates about 2 to 8% of all pregnancies. And just recently, we got it documented in one part of Uganda, northern part of Uganda, that it's about 4% of women that will have this complication in their pregnancy. Not so, I can't describe what it is for the rest of Uganda, but this is important because you might have had things like, oh, this condition is common in Africa, common in sub-Saharan Africa. And sometimes we say these things without actually documenting them. So this was a great reference to get at. But what is important as well is whether now this distribution is similar across the whole of Uganda, or it might vary by the region. So that's one question that I have no answer to, but one question for us to really think about as we move on. But undoubtedly, although it affects only 4 in 100 women, it's associated with severe maternal and neonatal outcomes. And that's what we are going to share in these slides. So our story today is really, I'm going to share what the trends were like. This is 2015 to 19 at our hospital, the maternal deaths and what the causes were. The hospital is in Mbarara Regional Referral Hospital, which is a teaching hospital for Mbarara University of Science and Technology. Then we shall also, I'll share with you the magnitude and risk factors for the adverse perinatal and maternal outcomes among these women. And then I'll also share with you their risk of remaining hypertensive postpartum. So these were 3 different studies. And the method for aim-1 was a retrospective review of maternal death that had happened in that 5-year period of time. And the practice is that audits are conducted once a death happens. So we were able to retrieve the audits reports that were available, and then we documented characteristics of this death. The second aim, we prospectively enrolled women who had a diagnosis of hypertensive disorder of pregnancy. This was in 2019, and we excluded women who had pre-existing hypertension. And these participants were observed for their perinatal and maternal outcomes. The third objective was that the women that we had enrolled in aim 2, we then followed them up to 3 months postpartum. That's 12 weeks. And we're able to document what their blood pressures were at 3 months postpartum. And we defined persistent hypertension as a blood pressure of greater than or equal to 140 systolic, or a diastolic of greater than or equal to 90 millimeters of mercury, or women who are still receiving their antihypertension therapy, because remember, this was a cohort of women whose pregnancies were complicated by hypertension, and therefore there's a chance that probably some were still on their antihypertensive medicines. Okay, so on maternal death. So we had a total of, if you can look here, this is the total 164 maternal deaths occurring over the 5-year period. And of these, this is about 75%. So we're able to retrieve audits in 75% of these women. Now, I told you I'll state some facts, which is what I'm presenting, and then I'll also suggest some interpretations which might come from my head. So one of them is this. So these were hospital-based maternal death. The caveat, though, is that these women were referred to this tertiary care facility. And I think sometimes we overestimate the maternal mortality ratios in some settings like sub-Saharan Africa, where we don't exactly have a very strict documentation of some of these things. So what am I saying? What I'm saying is that this is the maternal mortality ratio when you get the death over the total deliveries in this one facility. But remember, these women were referred from different facilities. So the argument I tend to make, therefore, is that probably the denominator is larger than what we do, and we end up overestimating the death. Undoubtedly, 164 women died, but whether it was out of 40,000 deliveries or more, that one I cannot confirm. So that's what we have. And then the report has 124 audits. This is just a graphic of how the trend was at the time, and the number of deaths were high in 2018. And if I had data for during the COVID period, you would see it would be higher because of COVID. Anyway, so what did these women look like, the women who died? I circled some important factors here. One is that they were young women, less than 30. Majority of them were less than 30, the age of 30. Why is that important? Because sometimes when we characterize adverse maternal outcomes, we tend to look at older women, and I'll also tell you why. The other thing is that the death, we had a couple of deaths actually happening in the antenatal period. And this is driven by, okay, yeah, you can have antenatal, you can have obstetric hemorrhage occurring in the antenatal period as antepartum hemorrhage. But I would argue that most of these drivers is things like hypertension and the indirect causes of death. Then you have a high number of antenatal death occurring. And undoubtedly, postnatal death are really majorly driven by hemorrhage, as we shall see in the next slide. Another important thing is that women were dying within hours of arrival. So this is a tertiary care facility, and over 40%. So 4 in 10 women of all that were referred died within less than 24 hours. And that means if you have to do anything, you have to do it within that very short time. Or on the other hand, it means that we are seeing very sick women at our facility. So the causes of death, in summary, the highest is bleeding, hemorrhage. The second is hypertensive disorders of pregnancy. The third are the indirect causes, and this is a cocktail of things, but mainly it was people living with HIV with complications of the disease of the HIV. And then some other cases, you have things like malaria. And you also still have abortions as well. Okay, so what does the first aim of the study show us? It shows us how important hypertensive disorders of pregnancy are. They are the second leading cause of death. And you can see the bulk of women are dying in the antenatal period. Okay, so that's one. So aim two was to understand the risks, the outcomes. What are the outcomes of the women who have pregnancy hypertension, and what are the risk factors in these women? So again, I highlight the age, and I'll put it to you that 80% of the women in Western Uganda were less than the age of 35. And that's important. And also, please remember, this is a cohort of hypertension. So every woman you see in this particular slide is hypertensive. So you look at their age. The other thing that I picked out was that you have about 12% of them who had a history of pregnancy hypertension. Why is this important? It's because maybe if we had intervened in the antenatal period and screened, maybe we could have altered their outcome for in this current pregnancy. I think the other thing I would want to highlight is gravidity. So yeah, so you can see majority of them had more than one pregnancy prior to this one. Okay, so that's important for us as we understand these women. What were some of the outcomes? The baby outcomes, the perinatal outcomes, you can see about 20% of them died. And then you had another group admitted in the neonatal care unit. So two things. One, they died, which is unfortunate. But the other is that if you have another about 40% needing neonatal intensive care unit, it then implies that care for women with high blood pressure, if you're thinking about health systems, then you want to think about a neonatal unit that really can take care of such these babies. So that's the other interpretation, that if they're not going to die, then one of the ways you're going to alter that is by providing a neonatal care center or unit for them. For the women, there were a mixture of outcomes, as you can imagine, but postpartum hemorrhage is in there. And remember, hemorrhage is the leading cause of death. So you can imagine a marriage between high blood pressure and hemorrhage, what that would mean for the mother. The other one is HELP syndrome. Some people will argue that maybe this is one of classifications of a disease. I would argue that this is also a complication of the disease. Not every hypertensive gets HELP syndrome. So that's why we classified HELP syndrome as a possible adverse outcome in these women. Okay, so now we were asking ourselves these are speaking about the predictors for adverse perinatal outcomes, and there were mainly two. Early onset preeclampsia, so that is hypertension. Sorry, I used preeclampsia and hypertension, but no, let's say hypertension. So this is when the hypertension in pregnancy occurs early at less than 34 weeks, the baby would have a challenge. But let's move closely together with the birth weight. Now, and again, as we interpret these things, two things will happen. If you're at a gestational age of less than 34, definitely your baby is going to be less than 2.5 kilos. But the other interpretation is that probably women give birth to babies with growth restriction. So babies born to mothers with whose pregnancies are complicated with hypertension are also likely to have some form of growth restriction. And therefore, although these two variables could seem related, I could argue that this birth weight stretches beyond just the 34 weeks to include term babies whose weight was still less than the appropriate weight for gestational age. So that's the interpretation here. But in summary, for adverse outcomes, early onset hypertension, and if the baby is small, they would have adverse outcomes, and probably these are babies that are ending up in the neonatal care unit. So that's the other point I was making. Okay, for the mother, the outcomes that we saw, one of them is that women who are referred were likely to have these complications. And the other was that women who unfortunately had eclampsia, as you can imagine, which is one of the extreme forms of this condition, are also going to have complications. And again, the interpretation here is that if you want to modify their care, then you want to think about the referral pathway. And the second point, you want to prevent them from sliding into complication territory. So the third question, and you can see that the presentation is almost coming to an end, but don't worry. So the third question was, do these women remain hypertensive after a pregnancy that is complicated by hypertension? So again, these are the characteristics of the women. We compared the women who presented their characteristics at enrollment, as well as the ones who had who remained hypertensive at 3 months postpartum. And they were all similar apart from their gravidity. And you can see that those who remained hypertensive, you can see the gravidity was a bit comparable apart from the prime gravida group, where you had actually less of them. But anyway, so this is a continuation of their characteristics. We also managed to do some baseline laboratory tests at enrollment to see if this predicted their risk for remaining hypertensive, because some of the risk factors for hypertension, such as their lipid profiles or their renal functions, tend to be altered in pregnancies complicated by hypertension. And so we wanted to see if this would predict women remaining hypertensive. So for this particular aim, what did we find out? So we found that about 40, so about 4 in 10 women who had pregnancy hypertension remain hypertensive at 3 months after delivery. One of the shortfalls we had, of course, like you can see in the notes below, we lost about 50% of our women. Some of them it was distance, some just lost contact. But remember, it's a referral center, so these are people coming from anywhere and everywhere. And so coming back for review at 3 months when they think they are well, you get such challenges as a loss to follow up. But needless to say, it's something we should interest ourselves in. And for any practitioners, you want to get into the thinking that probably what we thought before, that once the placenta is out, then the woman should be fine. We have to rethink that and try to think about their long-term care. So that's one of the implications of this particular work, is what does the life of the woman look like after she has delivered. And so this is something that we want to think about. Some people have called it the fourth trimester, but I mean, the interpretation is that there are women who are remaining hypertensive. Now, you might have forgotten, but let me just take you back to the age. And I told you over 80% of these women were less than the age of 35. And if you have that in mind, and remember we had a slide where we had a group of 20-year-olds as well. So if you have this, and then I say that we have 4 in 10 of them remaining hypertensive, it means that you have young people in Southwestern Uganda who are going to become chronic hypertensives at the age of 20, or at least less than the age of 35. So that's important. And so you think about their long-term care and what that looks like. In this particular study, it was the renal function that predicted their risk for remaining hypertensive. And it begged the question, of course, 2 questions from this work, and feel free to ask them again in the Q&A, but one critique is that how sure are we in this 40%? Some did not enter the cohort when they were chronic hypertensives. You remember in our enrollment, we excluded those who are chronic hypertensives, but it's possible that with our health-seeking behavior, we got women who did not know their underlying blood pressure. And that's why in one of the tables, I told you about 12% of the women in this cohort had a history of pregnancy hypertension. So if we are to use that argument, that probably those 12% carried on their risk into this study, and presents us with the 40% that we see. The other question is about the renal function. Of course, we verbally asked them if they had any known kidney disease, and they did not. And so whether this is how damaged the kidney is following the hypertension complication that then leads to the persistence of the hypertension, or indeed there could be women with undiagnosed chronic disease that entered into this cohort. So 2 important things. The third one is, of course, you want to think about their long-term care. Okay, so just briefly and quickly, other things that we've done around hypertension, and I'm just flashing these out. There's one on the eye conditions in pregnancy hypertension, so which was defined as retinopathy. And here we screened, this was antenatal, really, this was in the antenatal period, and we screened everyone who had a diagnosis of high blood pressure in pregnancy, and we found that 6 in 10 women had some form of retinopathy. And it was common, as you can imagine, among women with severe hypertension. And then just recently, you might have noticed that there are groups of people that are thinking about the role of the ophthalmic artery Dopplers in predicting preeclampsia. So that's one school of thought. The other school of thought is whether the eye would actually provide an indication of early onset, or helping us predict who might be at risk of having a pregnancy complicated by high blood pressure. So whether the retinopathy we saw was because of the high blood pressure, or women had something underlying, remains not clear. But I think any groups on call would be interested in knowing what happened to these 6 in 10 pregnant women, because this was a cross-sectional study. So whether this retinopathy resolves later, and what the predictors for resolution are, or it persists just like the hypertension, that question is still not answered. The second thing is the kidney function in women whose pregnancy has been complicated by high blood pressure. In our facility, it's about 4 in 10 women that will have some form of acute kidney injury. And again, this is common among women with eclampsia. So you can see retinopathy, severe hypertension, kidney injury, you have eclampsia coming in. In terms of acute kidney injury, again, if you're thinking health systems, then you want to imagine that beyond a labor suit for delivery and a theater for the C-sections, women also would need some form of dialysis care, and as well as a renal physician. So hypertension in pregnancy can present a cocktail of things where you also need a group of physicians around this mother to improve their outcomes. The other that we looked at was a phenomenon called non-proteinuric preeclampsia, because for some time now, the definition of preeclampsia had protein at the center of that definition. However, over time, new understanding has come out that probably protein in urine might not be as important in that definition as we can imagine. And from our study, at least 2 in 10 women had preeclampsia without proteinuria. That was important, and this was common among the first-time mothers, so prime gravidas. Okay, so as I go to the end, so that is, and I've been moving and also discussing some of these reflections, but I can repeat them. One of the reflections is when we think about trying to predict preeclampsia, for example, following this work, as you can appreciate that my group has done a lot in the epidemiology side on trying to describe these women, what they look like. We are yet to have an intervention. But if we are to try and predict preeclampsia in this setting and try to look at some of the models that have been developed by other settings, where they have emphasized age greater than 35 and null parity and things like smoking and high BMI. They are important, but whether these translate or reflect population in Uganda and by extension in sub-Saharan Africa, I'm not sure. I'm not sure. And some other things that you can think about when you read literature and they put race and they say the Black race, these are studies where you had different races. So is that variable still important when you're discussing a sub-Saharan population? Are you going to tell the clinician, or should people from sub-Sahara getting these books and looking at risk factors really imagine that Black people or African people are at high risk of preeclampsia? And I'm not sure. And that's why I said our societies need to investigate the incidence, the prevalence of this condition in their setting. At least the people from Northern Uganda tell us 4%, which is fairly comparable to high-income countries as well, where the incidence is about the same. So, so that's important, and that should really give some new thinking. Sometimes you tell people there might be something about just prediction in sub-Saharan setting, and they say, oh no, we know a lot about this. We did this in America, we did this in Canada, but whether that reflects the African population, I don't know. The second thing is what I shared, that you looked at most of these women presenting with adverse outcomes having a complication of this high blood pressure, and whether an intervention preventing complications would alter their outcomes, I think remains to be known. there might be groups on the call, and here I'm interested. Our group should explore more on qualitative things like what's the woman's knowledge about preeclampsia, what's their lived experience, do health workers know that this thing remains postpartum. So if anyone is interested in qualitative work, I would be glad, as well as what I said, interventional studies to push for the initiation of prophylactic interventions in these groups, and collaborators are welcome. Lastly is remember when we're discussing persistent hypertension, someone will say, what if this problem started pre-pregnancy? So there are groups that are trying to run pre-pregnancy cohorts, and my group is currently running a pre-pregnancy cohort, and we are describing hemodynamic changes, and probably in future we shall have a talk on some of our findings on whether pre-pregnancy characteristics can help us understand what women look like and their risk for cardiovascular disease. So this is an exciting field because running pre-pregnancy cohorts is not an easy venture, but it's something that is worth exploring even in our setting. So this is the work we are currently involved in. This is also a reflection that I got from a group, because I understand from our audience today, some of us are involved in what some people describe global health work. And I just want us to think about for a moment whether what we understand as global health is as it should be. So for some people, they wrongly or put it that someone to be named an expert is someone who is from the global north, has some projects running in the global south, and that person is a global health expert. Granted, fair, that's okay, and I agree. How about who then, how then can we define the guy from the global south? How does he or she become a global health expert? And these thoughts are important, because unless the people in the south get to see what happens in the north, they will wrongly, or at least they will tend to assume that what they've been told about the north is what it is, and they've been told about the south is what it is, and that there are so many disparities between the two. But I'll put it to you that you will appreciate that there are challenges in both settings. And I would put it to you that for me, a global health expert, or in any case, any answer giving a global health reflection must be getting the experiences from the two settings. So that's why I was making mention about the young ages. So for example, the women in the high-income countries are likely to have their first pregnancy above the age of 30, because in their setting, there might be things that push them to get to that age before they get pregnant. Whereas in the global south, you see a high number of women actually getting pregnant when they are still young. So those are two things, variables that we put into our prediction models, but they are being affected by something else. And after COVID, that something else was called the social determinants of health. And so when we deny people from the global south to understand the context in the north, then they will never appreciate that setting alone could bias what we think is either the risk or the solution to certain things. And so I make the last argument and say that we need to advocate for directionality in our work, because I mean, just think about it. A call will come by a funder in Canada who is calling people in Canada who have projects in Uganda. Now, whether that funder would run the same advert asking for people in Uganda if they have ideas to run in Canada is a weird thought I have, but I think that funder would have an interesting look on their face if I asked them for the same. So it has power dynamics around this, but if we are thinking of equity and we are really, we want answers to some of these questions, then you need the two settings to bring their experiences, and then it's the collection of those experiences that you call global health, not a collection of one's experience from one part of the world telling it to an audience in another part of the world. That is my reflection. Okay, so I think I've come to the end. I just put this QR code. So the work that I've presented is published work. Beyond the 30 minutes that I've spoken for, you will have some time to read more, critique these papers, see how best we can work. And I separated the two. One is the full list of publications, another is curated to just pregnancy hypertension. And as you look here, you can just scan the QR codes to get it. Okay, finally, I will run through some acknowledgements. My supervisors and mentors, I'm currently a PhD student at the University of Cambridge in the United Kingdom. And we are working with a group to understand cardiovascular changes in pregnancy, starting pre-pregnancy. So we are running a pre-pregnancy cohort in Uganda, but the same group in the UK is running a large cohort, Wellcome funded cohort for of about 3,000 women in the UK, getting their pre-pregnancy characteristics. The hypothesis is really that probably the women who get hypertensive in pregnancy were going to get hypertensive anyway, and that maybe, just maybe, pregnancy, which is a stressful event, unmasks their risk for hypertension. And so it quickens the onset of this hypertension. So we want to see beyond what other groups have described as placental pathology, our group thinks that maybe pregnancy hypertension actually results from maladaptation to physiological changes in pregnancy, that then for the women who fail to adapt, they get on to remain hypertensive. So I'm sponsored by the Commonwealth as well as a training grant from the National Institutes of Health under the MIHCAN or MIHCAN. So thank you very much, everyone. And I look forward to a very interesting discussion in the next couple of minutes. Thank you so much.
Thank you so much. I really appreciate you taking the time to come speak to us. It's wonderful to have a global health expert from the Global South. I think you put some very important points about that and about how we really do need to really highlight the voices of the people who have the local lived experience and of understanding of the region. We do have some questions, but just on that note, because we're talking about really, you were highlighting bringing more voices of people doing research on the ground who are from the Global South. Says, I see you're doing work on early predictions of hypertension. Is there local concurrent work being done on prevention or better understanding causes and contributing factors to the high rates of hypertensive disorders of pregnancy, generally or specifically to sub-Saharan Africa? So do you have any colleagues or anybody else who are also doing kind of more in the prevention side?
Yeah, so that's a great question, and shout out to all my Ugandan colleagues. You can tell the number of them on the call, but I'll single out Moses. So Moses is in another training institution, the largest in Uganda, called MIHCAN. So Moses Adroma is also one of the preeclampsia experts on that side. And they are running a pregnancy cohort to predict, to get a sense of what the risk factors for preeclampsia are in our setting. I also understand they are running, it might not be intervention, but one of the research work that they are running is around a drug called magnesium sulfate. So just to bring you up to speed, the maintenance dose of magnesium sulfate is 5 grams, and the injection is given 6 hourly. So this is a lot of injections a woman is going to get. So one group in Nigeria described that actually half of that dose, so giving it, I think they were saying if we gave it either 8 hourly or, anyway, if we gave it half of the time we are giving it now, that maybe there were no differences in outcomes. So the group in Mulago is trying to check if there are different, what should I call them, doses of dosing patterns of magnesium sulfate that would give similar outcomes. Lastly, to your question, I think is one of the things I highlighted in the slides, that we need to run intervention studies, at the level of prediction. So when we say aspirin improves outcomes, what's the use of aspirin in our setting? I mean, the Ugandans on the call, as should be honest, we don't necessarily at least actively screen, but we have it in the guidelines. So we have it in the guidelines, but we don't do it. So that is something that we need to strengthen. The other thing is, I talked about the referral pathway. So once a woman has hypertension, what things should we do around referral that can alter their outcomes? So again, that's another area for intervening. The third one is really going into these audits and understand why women are still dying. Because if you look at all these causes of death, without a doubt, hypertension in pregnancy, take out eclampsia, take out acute kidney injury, my hypothesis is that we shall reduce maternal death by 20% by just preventing these women from going into complications. So those are the 3 different things I could think about. Yeah, thank you.
Wonderful. Hannah Gaza mentioned the retinopathy piece. Sounds really interesting. How predictable is it? And wondered if about the applicability in North America.
Yeah, so I'm not very, I might not be very certain, but actually, interestingly, for you in North America, did you say North America or North Africa?
I think she said North America.
North America.
Yeah, it should be, because I mean, what I'm saying is coming from your end. So it's coming from a group called Maternal Fetal Medicine. So this group, in their type prediction models, one of the things they have added now is the ophthalmic artery Doppler, and they hypothesize that it's working better than the uterine artery Dopplers in predicting preeclampsia. So it's a novel area. It's still open to discuss. It's open for you to find out the logistics of doing it, what instruments you need to do it. Yeah, but it's all out there. So the maternal fetal medicine group, I think it's called Maternal Fetal Medicine, either Foundation or something. So that group is where they highlight in their prediction models the use of the ophthalmic artery Dopplers. Yeah.
Thank you. Yeah, I think we do really need to delve a little bit more into that. I'm curious because I haven't heard too much locally on that, and I think the more ways we can look at it, the better. There is another question, which is, what is the current postpartum follow-up schedule for hospitals in Uganda? So I know in Canada, generally it's done for about 6 weeks, and that would then be able to catch a portion of the kind of remaining hypertension. So how are hospital and birth workers currently catching the patients who remain hypertensive?
Yes, and without a doubt. So I mean, it's similar. So women have a scheduled 6-week visit. But before that, ideally, they are given hypertensive medicine for 1 month. And the idea is that after that 1 month, you should be able to have your blood pressure checked again. And that fits perfectly well in the 6 weeks. If you're still hypertensive, then the logic would be that we maintain your drugs for some time. Now, again, there's a window for improvement in there. The first one is that in Uganda, there is vaccination for children for polio around that time, the 6 weeks period. So if anyone is thinking of strengthening the health system, that is one point of care you want to dive into and get those women when they have come to bring their children for vaccination. Do we routinely measure their blood pressure when they come? I don't know. Maybe when they bring their babies, we just immunize the babies. So that is for anyone on the call from Uganda and they're thinking about these things. You want to design something around that time. It could even be a simple cross-sectional study to find out what blood pressures look like in the postnatal period among women who are coming to attend postnatal clinics. So the jury is out there. The standard of care is what I've said. They'll have the 6 weeks. And our current talk is that now we need to find a way of linking them into long-term physician care for those that find hypertensive beyond that point. Yeah.
Thank you. So yes, were there any other questions? Dr. Schroff, I'm not sure if you had anything on your side as well that you wanted to ask.
Yeah, I just wanted to say thank you so much for this presentation. At the beginning, I really I did this when I saw how many really young women are actually dying at your hospital. It does seem like a really serious issue. And then as I heard you present, I felt like they were in very good hands and that your staff is extremely competent and qualified. And I have a lot of questions, which I don't think we have time for, just about the context, because I didn't get a sense of how are women transporting themselves to the regional center. Is that part of the delay? Is that why over 30% of them are dying, within the first few hours? Is it because they've gone from one hospital to another, and it's just because they are, like you said, they're sicker when they arrive, and that's why you need to do something really quickly? Yeah, and I was really wondering about the hypertension. Somebody asked about prevention and what kinds of things are you able to do prenatally? You showed like a fairly high rate of obesity, obviously, which is related to hypertension. So yeah, I was wondering about what kinds of things, say, are you doing in family medicine within the context to address the issues related to hypertension, and just stress reduction in general. When I was in Uganda, I had the honor of doing a talk. It was a continuing medical education talk to all the OBGYNs, and I remember seeing just an incredibly talented pool of people you have there. Last thing I did want to just ask you, because you really did I thought you really went through a lot of your own publications and then topped it off by talking about how critical it is for voices like yours to be the experts in sub-Saharan Africa, and how critical it is that we decolonize the entire practice of global health, and to show the expertise for where it lies in people like yourself. And so just two blue sky questions for you. If you could have a, a, a perfect scenario or a really good scenario for the pregnant people in your region, what would that look like in terms of their care, in terms of their determinants of health? And then just in that blue sky scenario, what would like a decolonized system look like to you?
Okay, very, very great questions. I think, Farah, you remind me of the last question in case I forget it. But just, I flashed this slide just to answer the question about the delays. If you look into this corner here, most of them, it was the delay at home, or what we would understand as delay one, so delay in making the decision. I was waiting for my husband to come back. I didn't have money. I was trying to get a car. And of course, tied in well with delay two, which handles, the logistics of how you get onto the point of care. And that's a perfect point that you make, that indeed, just these two issues, you can see they are before the health facility. But even between home and the tertiary care facilities, the lower center where they went, and then probably there is no ambulance to shift them over. So there are really challenges with, linking women into tertiary care center by way of lack of ambulance, the terrains and things like that. But beyond that is the argument I make for the social determinants of health. So things like poverty or lack of money, things like education. So women can tell that if you have a headache, then that's a bad sign. Or they told them things about, preeclampsia and hypertension, and they just did not understand them or synthesize them. So you can see educating women alone. And as I make this point, I also think that this is one of the differences between low-income and high-income countries. Just that the infrastructure, how the roads and things like that, and these disparities. But by extension, when you think about them and you look at populations from high-income countries and they disintegrate this information by race, you find that the minority groups are deprived in some of these ways economically. They can't get services on time and things like that. So you want to think about it that way. Perinatally, what can be done? So from the work we are doing, part of the things we shall push for are perinatal clinics, and then design things like you're saying, what can women do about their BMI? What can they do about their stress reduction? How about women who are hypertensive and they did not know, so they would start antihypertensives, would start aspirin for some of these women. So the answer to your question is really the nuance would be a perinatal clinic service in our setting, which is currently not very active. So the last point was the perfect scenario. And I might not answer it directly, but let me make the point. So my experience in the UK is, I'll tell it by way of a story. So a woman had a headache, a pregnant woman, calls the hospital that she has a headache. Someone at the hospital picks up, tells the woman, go and have your blood pressure checked. Indeed, they checked it. It was 200 over something. She was admitted for just 24 hours in that facility, managed with the hypertension, sent back home. So the healthcare in the United Kingdom is midwifery led. So the following day, the midwife went over and had the blood pressure checked, and it was still high. And then the decision was made to deliver. I can tell you without doubt that you would get the exact opposite in our setting. The woman might not know that headache in pregnancy is bad, to make the phone call. She doesn't know who to call because probably there are no centralized calls for the health system, and and then you don't have people being able to come back. So again, in this whole global health space, Farah, the question I would ask is, why did the woman in the United Kingdom with high blood pressure survive and a woman in Uganda dies? And I'll tell you, it has less to do with the biology and the science of the disease. It has a lot to do with the social determinants of health. And the decolonization is actually away from the North. The people in the South need to invest their resources into their people. They need to invest money into research to understand their circumstances, because I argue conservatively, saying we are getting money from Canadians and then run by Canadians, but I have to be very conservative with that because it's money from Canadian taxpayers. What the Global South needs to do is to invest in its healthcare and probably a health insurance model that allows these women access to care just as it is in the United Kingdom. Thank you very much.
And if there's any last questions, I don't know if Dr. Henry has a moment to wait. But okay, great. Yeah. Any other last questions? I know I have so many questions, so I'm gonna have to contain myself. So yeah, welcome, Derek.
That's Derek. Derek is an obstetrician from Uganda, but currently working in Rwanda. And he maybe next time he will tell us about the health insurance system in Rwanda, because it's better. And I think it serves the purpose. And yeah, anyway, so I think Derek listening through appreciates some of the comparisons I'm trying to make, that even in the global South itself, there are differences that, we need to harness.
Yes, please, Dr. Derek, please do get in touch with us. And yeah, we'd love to hear from you. I'm going to put my email in the chat.
I was just saying, thank you, Henry, for the presentation. Yes, I'm Derek. I'm a practicing obstetrician here in Kigali with the Rwanda Society of Obstetricians and Gynecologists. And I followed very keenly on Henry's research, and I think he's doing us justice over there. Yes.
Thank you.
Absolutely. A rising star from Uganda. Yes, very beautiful.
Certainly.
Wonderful. Yeah, I think one of the things that we really try to focus on with these webinars is we've got such incredible experts from really all over the world. And we really want to utilize this platform for everybody to meet each other and to be able to start collaborations and further collaborations because there is, I think you say, there's so much work that's being done locally. And really we need, it's a lot of the time it's just a matter of being able to connect and join forces to be able to make the impact. So I really appreciate everybody who does tune in for these and shares their knowledge, because it's really incredible the work that you're doing, Dr. Lugobe, but then also everybody else who's on here is really making a big impact.
Absolutely. Yes. Well, are there any other comments from anybody or any last things that people want to say? The one thing that you might have noticed in Dr. Henry's last slide was that he is really open to collaborations. And so any of you who do have an interest in working in Uganda, working with him particularly, he said he needs more qualitative studies being done, more intervention studies. Yeah, so please do keep that in mind. That was an invitation, and you'd be very lucky if you went to work with him. So
yeah, indeed. I mean, to be honest, although we are pushing decolonize this, decolonize that, the funding honestly is coming from your end. And part of the terms is that they need people from your end, to partner with people from our end. And it's a bit different if you say, hello, come, let's think together, as opposed to, hey, I have this idea, I want to run it down there and see if it works. So there are two different approaches, because what you're selling might not be what is intended, and maybe we have something else different. But I mean, for the purpose of the Canadian spaces you occupy, if you see some grants that are calling for work in low-income countries, please feel free to reach out, and let's build this thing together. Yeah.
Yes. 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 From my Edna Anand is speaking. Oh yes, this is a very, very esteemed leader from Somaliland. Welcome, Edna Anand. Can we unmute?
And now you just have to hit unmute. I've put ask to unmute.
Got it. Yeah.
Oh, perfect.
Well,
yes, you're there.
Thank you very much. It's an honor to join you and to listen to the concerns that Dr. Mark had about hypertension in pregnancy. As he said, it is one of the biggest killers of pregnant women in my country, Somaliland. In fact, it accounts for 20%, 27% of our maternal mortality nationwide, mostly due to lack of prenatal care. They have been convulsing in the home for 2 or 3 days before they are brought to hospital, if they're lucky to be brought. In fact, the miracle is how some of them survive. having been unconscious for several days. We would like to partner with people. We would like to share experiences with others. Our email is ednahospital@yahoo.com. We train doctors and midwives. We try to send them out to the countryside on outreach programs and activities. But this is a very difficult battle that we need to join hands and share experiences to try and save our women who are dying of such a preventable cause. So thank you for allowing us to join. And we're open to partnership, we're open to consultation, we're open to sharing experiences, as I said. And thanks to all who are doing something about saving mothers. Thank you.
Thank you, Edna.
Yeah.
Thank you.
So we have the Edna Anand's email here, and I think it would be really exciting. We've got people from Rwanda, Uganda, and Somaliland. I mean, you're really far from each other. The geography is massive, but still much closer than we are to you here in Canada. And I think the brilliance and the capacity of all of you, like, to me, that's where the dream really starts, where people in the region start really working together and really lifting up the health. Like in this case, we're talking about hypertension and pregnancy, but really we're talking about raising the status of women, the social and economic status of women, because that's where it all starts. If we really want to reduce maternal deaths, we have to start with little girls, educating little girls, making sure they don't get married early, making sure they get lots of education, right? It all starts there.
Yeah, I mean, sorry to drag this on, but I think we are coming to a close. Just what I can say as I conclude this is, the more I look at the maternal death audits, and this is the point I'm making about bi-directionality. I mean, I met guys in the US at the maternal fetal medicine foundation meeting, Farah. I managed to go in one of those, and the guy says we've never had a maternal death in like 10 years or something. If you get a practitioner from the South listening to this person, going into their environment, understanding, let me tell you, one thing I appreciated for myself was to say we are doing a lot of work here in Uganda. We are doing all we can do to save these women. But then it channels your thinking away from the science and the medicine to actually saying, if we don't advocate for these social determinants of health, this situation won't change. We can sit, do the audits, but it comes back to the same. She delayed to get care. There was no medicine in hospital. The husband did not come through. Those things are not in medical school. This is the woman's life that is being impacted by something else. So I'm happy to talk next time about decolonizing, Farah. And maybe once our work with preconception cohort is done, once my PhD is done, which is next year, I'm also happy to share with you some of these changes and seeing what other possibilities ahead. Thank you very much for this opportunity. I met Farah how many years ago? 4 years, 2020, in an online meeting of the Society of Maternal Fetal Medicine that we didn't attend because of COVID. All of us, it was online. Since then, I told I wanted to do a PhD. She said she had no offers. And yeah, I ended up with the British people who have been very kind to me for now. Yeah, thank you very much. Hopefully I'll visit Canada as a tourist or a work colleague or global health expert from the South.
Global health expert. That's
Yes.
it. That's
Thank you.
what.
We would love that. And I'm so sorry that I couldn't take you on at that time. Yes.
It's fine.
Yes.
It's
Look
fine.
at look at what you've done.
It's fine.
Yeah.
Well, thank you everybody for tuning in. I know we've gone a little bit over, but it was just so wonderful. It was worth every minute. And so we hope that you tune into our next webinar, which will be in 2 months' time. So stay tuned for that. And yeah, thank you to Healthy Seminars who always host us. So we really appreciate that they do that because it's good to have a platform for us all to connect. Again, thank you so much for sharing your your knowledge. It's been wonderful, and it's really nice to see we've got so much power in this one call. So it's exciting to see what's going to be what we can achieve all together. So thank you, everybody.
Thank you too, and have a great day. Bye.
Thank you. Thank you. Keep up the
Bye.
amazing work.
Thank you. Bye.
Bye-bye.